For this session, I'd like to invite Dr. Jacob Creswell from Stop TB Partnership, Dr. Elana Van Brakel from IAVI, and Mr. Hirotaka Michiba from Fujifilm Corporation. Dr. Fortui from TB Alliance and Mr. Ohashi from Toyota Tsusho Corporation listed in the program are unfortunately not able to join the forum today. Thank you for your understanding. Ms. Eriko Koyama from the GHIT Fund will moderate the discussions. Eriko, the floor is yours.
Thank you, Naoto, for your kind introductions, and apologize for my breaking voice. I lost my voice this weekend and it's just recovering, so please bear with me. And thank you for all my speakers today joining today. And we have a variety of speakers on the floor covering the landscape combating against tuberculosis, TB, with treatment, vaccines, and screening detecting devices. The speakers give the presentations first, followed by the panel discussion, and we will also get some questions from the floor when the time remains. Please allow me to introduce Dr. Jacob Creswell from Stop TB, the first speaker of the day, covering the current status of NTB strategy and the missing pieces to fill the gaps. And Jacob, you have kindly included the landscape of TB treatment in your presentation to cover the part of NADA from TB Alliance who couldn't be available today. And thank you again for accepting our final request to you. And Jacob, if you could start your presentation. Thank you.
Thank you very much. I also have to apologize for my voice. I think it got left on the plane over here. My name is Jacob. I work at Stop TB Partnership in Geneva. We're a UN hosted entity and work in many different areas. My area of work is mainly focused on diagnostics, which I'll be talking about today, as well as some words on new therapeutics and the needs. Just to get us centered and focused on why we're interested in this disease. Tuberculosis currently kills more people than any other single infectious disease, replacing COVID after a few years. And over the last 2 centuries has killed, by some estimates, more than 1 billion people. It continues to be a huge burden, even though we have treatments that will cure 85, 90, 95% of the people who we are able to reach with treatment. TB is airborne, and it has people who are infected can remain infected their entire lives without falling ill. We think that maybe around 2 billion people globally are infected, and this leads to a reservoir of people who fall ill every year. And right now, the WHO estimates are just short of 11 million people who fall ill. The 30 high TB burden countries account for more than 80% of the people who get TB every year. And in addition, as mentioned, AMR, clearly a big topic. There's a huge number, I think, depending on who you talk to, that the 400,000 WHO estimate in terms of drug resistance may be an underestimate, but that's a discussion for another day. In general, a huge burden. Stop TB, among different things that we do, we produce a roadmap to end TB. The global plan to end TB we just updated with numbers from to align with the recent high-level meeting on ending TB, and to address the impact that COVID has had on the epidemic. And we clearly will need a combination of new tools and approaches, as well as a lot of investments to end TB. And I'll talk about a couple of those, and other speakers will touch on different areas of those tools that we will need. So this is the gap that I would consider the most important one that we face in TB right now. The gap between the number of people who are detected and treated, notified, and the number of people who WHO estimates to get sick every year. Generally speaking, we're talking about 1 in 4 people who are missed by the programs and the systems, the health systems that we work, and that those 2.5 to 3 million people every year is the main reason who we miss is the main reason why TB kills so many people and leads to ongoing transmission. So why do we miss people with TB? I think the number one reason is a lack of access to care. When people seek care who have TB, we know from many studies that where they generally seek care, they do not have access to TB diagnostics. When they do arrive at services that provide access to TB diagnostics, those diagnostics traditionally have been rather of poor quality, not great. We had one diagnostic test essentially for about 100 years, and now I'll talk about the new diagnostics. But when people do arrive at health facilities, they're often not identified as needing a TB test, and the tests that they get are often not as good as they could be or we would like them to be. And then there's also a gap of linking people who do have TB to proper care. They can fall out, again, because of access issues. And also a lot of people seek care in the private sector and they're not linked to national TB programs. So as I mentioned, WHO has approved now several different diagnostic tests in the last 14, 15 years. For really 100 years, we were focused on smear microscopy, which has many limitations and generally not great performance in many populations. We now have tests that are much more sensitive, perform much better, but they have their own limitations. And they include technical ones and cost issues. So most of the more rapid, higher sensitive molecular tests that you can see here, expert, many of you will have heard of, and there's other tests as well, rapid molecular tests that are approved. They require a fair amount of infrastructure, and most facilities that have these tests will be at the district hospital level. And generally speaking, this is one of the main reasons why even 14 years after expert was first approved by WHO, less than half of people who have TB get a rapid molecular test as a first diagnostic, and it's around access, it's around cost. The other issue is that most of the tests are sputum-based. Almost all of the tests are sputum-based. Microscopy, obviously, and expert, MolBio's TrueNat, LAMP. Many of these tests are sputum-based, and lots of populations have difficulty producing sputum. Children is an obvious one. People living with HIV is an obvious one. But also women, a number of studies have shown that women have lower rates of producing quality sputum. So there's a lot of barriers to just getting a good sample to be tested. So one of the areas that we're really excited about is identifying potential new tests that use different types of samples. Tests that could use urine or capillary blood or an oral swab could greatly expand access to testing, even if the sensitivity of such a test is not quite as good as the molecular tests that are currently being used. Lower cost testing clearly has another advantage where you can begin to use those tests at a much wider scale and think about upfront testing to a much greater range of people who have maybe fewer symptoms, maybe asymptomatic, where we know that a large proportion of people who have TB from prevalence surveys are asymptomatic. Yet, again, the focus of TB programs has been waiting for people to come to health facilities complaining primarily of cough. Easy to collect and test. New tests that have samples that are easy to collect. We can also think about as we all know very well from the last few years and COVID, moving to at least, if not self-testing, collection of samples, being able to provide tests in private sector and pharmacies that people can reach much more easily, and that's where they go generally first anyway, is potentially a great area of interest and improving access for people with TB. And these self-testing have been shown across disease areas to reduce stigma associated with TB testing. So just a general graphic of what I'm talking about. If we just think about a test like Expert or TrueNat, has 80, 85, whatever we decide, it's not totally important in terms of sensitivity. But it's an $8 test. It uses sputum. It needs electricity. We will be limited in terms of our budgets and reach in the health systems where we're working. And even if you had a test that had lower sensitivity but had lower costs, could be used much more closer to point of care, point of need, we may be able to reach far more people with TB. I will not spend much time, but I do want to mention, and Michiba will talk more about X-ray and the really wonderful opportunities that we have with not a diagnostic test, but a screening test. Chest X-ray right now is probably the best screening test that we have for TB. And after many years of WHO and the TB community saying that we shouldn't be using X-ray, it's being embraced now more and more, and artificial intelligence has allowed the real expansion of the use of X-ray, because one of the major barriers of using chest X-ray, of course, you need someone to interpret that X-ray and make a decision to test or not to test that person if you're using it as a screening test. And artificial intelligence has the potential to really allow a much greater expansion. So we're quite excited about the possibilities that you can couple X-ray with some of these new diagnostic tests that may be developed. So I'm just going to spend the last few minutes, and you'll apologies and accept this is not my general area of expertise, but just want to talk about the next in terms of cascade of care for people with TB, getting people on to treatment. We have treatment for people who are infected with TB, drug-sensitive treatment, treatment for people who have drug-resistant TB, and they all have, we've made huge gains actually in many of these areas, just like we have several new tests for diagnostic tests for TB and screening tests for TB. We've had a lot of advances in the pipeline for therapeutics, but we still have a long way to go. This is data from a screenshot from TB Alliance's site around all of the different trials and compounds, regimens that are being worked on. We are in a really good situation, comparatively speaking, with all of the interest and investments and products that are coming out with new molecules, new TB regimens, target populations new formulations for pediatrics, drug-resistant developments. So this is clearly good progress, but we still need regimens that are shorter, pill burdens that are much lower, with fewer side effects. We made great progress getting rid of or moving towards getting rid of injectable agents that have terrible side effects for people, especially with drug resistance. Then we still need to do more, for instance. And we have shorter regimens. Introduced a couple of years ago, a 4-month regimen for susceptible TB, but it's much more expensive actually than the current regimen, and uptake has been very low, even though it has done quite well in terms of performance, on par with the current regimens, but because of the costs, uptake is low. One of the things that the Gates Foundation has been currently supporting, I think there'll be some news out about the current situation with the pan-TB regimen. I think it's still there's things that need to be worked on, but the idea of having a pan-TB regimen that is really much shorter than the current standard, 2-3 months long, could cure many more people with TB, reduce transmission, reduce burden on health systems if you can cut the time that people are on treatment in half or even more, and really permit more resources again to that area of focus, a huge area of need, the people that we currently miss. So just to close and say that we are at Stop TB Partnership, and I'm sure I speak for the other speakers in TB, that we really want to engage new developers, groups that are interested in this type of innovation, and have a dialogue, because I think that dialogue is going to be really important about how best to think about what technologies, what products will work. And at Stop TB, we certainly look forward to those discussions. Thank you very much.
Thank you, Jacob, for your wonderful presentation and covering also for the TB therapeutics part. And it was also great to know that there have been some achievements in the past decades, but still we have a gap and we need the new technologies and advancements. So that was really good to know. Thank you so much again. And please allow me to move on to introduce my next speaker, Dr. Elana van Brakel of IAVI, and covering the landscape and needs in TB from the perspective of vaccine development. So Elana, it would be great if you could start your presentation in 10 minutes.
Thank you very much, and good morning, everyone, and thanks to GHIT for this opportunity to speak about TB vaccine development. Jacob has very nicely set the stage for the size of the TB pandemic and the problem, and we know that there really is an urgent need for TB vaccines. No infectious disease has ever been eradicated without an effective vaccine, and TB will be no exception. I won't go through this because thanks, you've already covered this. We know that almost 90% of TB disease are in adolescents and adults, and it's also been over 100 years that we've had one vaccine, which is BCG, and we all know that BCG it's only partially effective in preventing and prevents severe disease in children, but not disease in adults and adolescents. Multiple new TB vaccines that work across all age groups, particularly among adults and adolescents, will be critical to eliminate TB by 2030 and to meet the WHO end TB targets. The public health return on an investment of new TB vaccines is also well established. Every $1 invested in delivering a new vaccine for adolescents and adults is projected to generate $7 in health and economic returns over 25 years. And what this looks like in a low and middle income country, where a TB vaccine that is 50% effective in preventing disease amongst adults and adolescents over 25 years, it will avert millions of TB disease cases, millions of deaths, and billions of dollars in costs carried by affected TB households. So as a vaccine developer, there are different strategies. You need to decide what your vaccine is for. And in terms of endpoints for our vaccine trials, we have non-traditional endpoints, such as the prevention of infection or prevention of recurrence or therapeutic vaccine trials. These are useful or could be useful to streamline and accelerate down selection of vaccine candidates, but can also lead to termination of a vaccine that could have been a good vaccine as a prevention of disease vaccine, which is the WHO preferred product characteristics endpoint of choice. And we really need to gain efficacy trial data towards prevention of disease. And this is also the most important strategy to meet the NTB 2035 goals. And if we think about prevention of disease, and actually, if we think about our strategies for TB vaccine development, we need to make sure that these endpoints are clinically and epidemiologically relevant and that they relate to the natural history of TB disease. And we now know that that is actually a spectrum of disease states, from infection to asymptomatic disease or subclinical TB, as it's also called, to active TB disease. And if we think about prevention of disease, we also need to decide or figure out how to test subclinical TB disease, or how to bring that in as an endpoint in our prevention of disease trials. And also to understand subclinical TB better, because we still don't know a lot about it at this point. And a lot of work is happening in this space. So if we look at the TB vaccine pipeline from the different colors, you can see that there is some diversity in the vaccine platforms. We currently have 15 candidates in clinical development and 12 candidates in active clinical trials. An obvious strength of the pipeline is the very promising candidates that we have in phase 3 at the moment, which is MTB-VAC, which is in a phase 3 trial for prevention of disease in infants, and M72 AS01E, the Gates MRI vaccine that is being tested as a prevention of disease in adults and adolescents. One other positive thing about the pipeline is also that we are now seeing for the very first time mRNA candidates entering in phase 1. And some other new protein adjuvant vaccines, and also a viral vector in phase 1. But the greatest weakness of this pipeline is the inverted nature. We have actually very few candidates in phase 1. If you remember the drug slide from TB Alliance, how many phase 2 trials is happening, and we don't see that in our vaccine pipeline. And what happens if those phase 3 candidates fail, which we hope they won't, but it is a problem in our pipeline. So if we think about challenges in the TB vaccine development, we can look at them across all the stages of vaccine development. In the discovery and preclinical phase, we know MTB is really a complex pathogen. It expresses more than 4,000 antigens. TB is a complex disease. We don't have a validated animal model, and we don't have a correlate of protection. In our early clinical studies, our dose selection or dose refining strategies are very limited, and we don't have a human challenge model to define this. In our later stage testing, our late trials are very long, very costly, very large, and this is further complicated by lack of a validated correlate of immune protection and also insufficient funding for this late stage TB vaccine R&D. And then, of course, we can develop a vaccine, but we also need to access the populations that will really benefit the most. Ultimately, we need adequate funding, political will to ensure market success. So now I'll quickly speak to you about MTB-VAC, which I'm very passionate about, as Harvey is a clinical development partner in the adults and adolescents prevention of disease development. It really is the only live attenuated MTB vaccine in development. It was derived from a human MTB sample or strain and was designed by Professor Carlos Martin at the University of Zaragoza when he deleted 2 genes from the original pathogen, which resulted in MTB-VAC that is an MTB, but it's less virulent and it is more immunogenic. And in all the preclinical testing that has been done comparing MTB-VAC to BCG, these studies have all shown that MTB-VAC is as safe as BCG, while more immunogenic and protective. And from a clinical perspective, why we feel that MTB-VAC really is a uniquely promising vaccine, it does have this broad antigen presentation. If you think about MTB and only the 2 deletions that created MTB-VAC, MTB-VAC contains all the antigens that was present in the original pathogen, even ESAT6 and CFP10 that is deleted in BCG. MTB-Vac is also a single-dose vaccine for improved adherence and feasibility. It doesn't require an adjuvant. It's got a low cost of manufacturing process, and already affordability commitments have been made. And there is a global manufacturing footprint with manufacturing sites lined up in South America, India, and Europe. So this is the critical milestone that MTB-Vac is approaching. This is the IAVI-sponsored phase 2B prevention of disease trial in adults and adolescents living in sub-Saharan Africa. We are hoping, or we're planning to start this study in the first quarter of 2025. We will attempt to enroll 4,300 adolescents and adults between the ages of 14 and 45 years. These participants will be healthy. They will be IGRA positive, meaning that they have been exposed to MTB before, and they will be HIV negative. They will receive the vaccine or placebo on day 1, and then we will follow them for 24 to 36 months. Looking for 35 TB endpoints or TB cases meeting the primary endpoint definition, which is pulmonary TB diagnosed with at least 2 positive diagnostic tests, and these are all from sputum, which is still what we are using in our clinical trials. And while we're only starting the trial in the first quarter of next year, we are already thinking about opportunities to accelerate MTB-Vac towards licensure and global equitable access. And we hope to do this by enrolling or expanding the trial to include the relevant populations that will generate the data that will support licensure. So this would be expansion to include a population of people living with HIV, safety, and that will be efficacy testing, and then safety and immunogenicity testing in a cohort of IGRA negative participants, and also expanding the trial to additional geographical settings like Southeast Asia or South or Latin America, and then also regulatory and access support to ensure that if the vaccine trial results are supportive of a licensure indication, that we can rapidly deploy that to where it needs to go. So in conclusion, this really is a truly exciting time in TB vaccine research and development, and I hope you can share that excitement with me. We have these late-stage trials with the potential to deliver long-awaited TB vaccines before the end of the decade, and I've highlighted MTB-Vac and also M72 AS01E. These efficacy trials are also contributing valuable samples towards identification of a correlate of immune protection. However, these are the initial steps, and we do need broader support and increased funding to bring these and other candidates to the finish line. And I'll end on this slide to gratefully acknowledge the generous support from our various funders. Thank you.
Thank you, Elana, for your presentation, and also sharing the lack of the clinical trials in the phase 2 in the vaccine development. However, also we're seeing some hints or slight advancement in the MTB-Vac. So yeah, congratulations, and we hope that everything goes well in the future. So the next speaker will be Mr. Hirotaka Michiba of Fujifilm, and covering the new approaches in screening at tuberculosis patients using the portable X-ray devices, as Jacob has kind of briefly touched upon, and who's also delivering it to the last mile along with together with Totetsu Show. And unfortunately, Yuta from Totetsu Show cannot join today, but Hirotaka has kindly accepted to talk about his part as well in his presentation. So thank you again, Hirotaka, and please start your presentation.
Okay, nice to meet you. My name is Hirotaka Michiba from Fujifilm and the Government Relations Division. And thank you for giving me the opportunity to introduce our activities using portable X-ray to TB, tuberculosis. And Fujifilm is maybe famous for the photographic film. This is our original business, but now we did expand our business to many fields, and healthcare area is biggest now, and our strong point is making good images. So we have many portfolio of medical equipment related to the diagnosis, imaging diagnosis like X-ray and endoscopy and ultrasound or something. And today I'd like to focus on our activity to TB. And TB is as you know, disease that can be prevented and treated. But every year, 10 million people, approximately 10 million people who develop the disease, and about 30%, it means 3 million people cannot receive treatment and diagnosis. We think the main challenge of TB care is access. As Dr. Jacob mentioned, access is very important thing in adequate access to medical care, and technique and knowledge and culture also. The developing country have not that kind of matter, so we have to do many activities. And I'd like to say thank you for GHIT. They long time supported us. We have the solution for TB, two big solutions. One is portable X-ray, and one is the urine assay, LAM assay. This can take the TB LAM by the urine sample. We joined many international events and seminar supported by GHIT. And this is our solution. Our product is named. Our product name is FDR-XR. It have only weight 3.5 kilograms, so we can put every necessary equipment into the one suitcase and go around anywhere. So we can bring it rural area and take chest X-ray, and also bring the CAD AI, so we can take the AI images on site. And I'd like to mention about the Stop TB partnership support, and our activity is every time supported by Stop TB partnership. This photograph is our headquarter office, and our top executive manager and Stop TB team, Stop TB partnership kindly come to our headquarter office in Roppongi. And thanks to the Stop TB partnership, we are listed to the GDF catalog. GDF catalog is a list of the effective equipment or services to end TB. We are our product is listed on that list. So our product is epoch making to bring to the rural area and developing countries, because conventional general X-ray solution, the room X-ray, needs the dedicated room and stable power supply and specialized radiologists. So our solution package can be carried anywhere, and every equipment has built-in battery, so we don't need to plug in on site. So, and we also bring our AI-based diagnostic support to on site. And this is the part of our activities in focus on Africa, and Ethiopia and Nigeria and Lesotho. So other country, many experience we have. And today I'd like to introduce our Cameroon cases. This is the collaboration project with Toyota Tsusho and supported by Stop TB Partnership, TB Reach. And from this slide, Toyota Tsusho made it, but let me introduce on behalf of them. And yeah, they have vehicle because they original business Toyota vehicle. So we collaborate. They can go anywhere with their Land Cruiser, and our portable X-ray is very sophisticated combination, I think. And they modify the back door to equip our X-ray to the door. So this as a like this picture, they can take chest X-ray the backside of the Land Cruiser. This is a special customized. So we did the screening, not only X-ray, chest X-ray, but also PCR test on site. So we bring PCR test mobile and Cepheid. And this is Cameroon maps, and area intervention is North region. North region have only 3 stationary digital X-ray instruments in the region. 3.2 million people total, but only 3 X-rays, so they cannot access to X-ray ordinarily. So this is a picture. Travel to remote locations with Land Cruiser and staffs and equipment, and set as a mobile health camps on site, and they built the simple camps and do X-ray, chest X-ray, and doing PCR test on spot. And this is a result of from 21st June to 15 November to this year. And yellow point is our camp point. So many points we covered, and at result, we took 88 TB positive cases in this through this project out of 14,000 people, 40,000 screened cases. And we narrowed down the PCR test by the chest X-ray. Chest X-ray detect the symptom of abnormality, and we did the PCR test. PCR test need some consumables, so we should narrow down the cost and time and labor. So this kind of approach we did took the 88 positive cases. And this is our final target. Our and portable X-ray can detect not only TB and chest X-rays, but also bone and abdomen. Many cases we can take, abnormality we can take. So we'd like to distribute this solution to the primary care in the world. A primary care center cannot have any equipment and cannot do primary care on site. So people have to go to the central hospital very, very far from their home, and it takes many time and money and cost. So we'd like to expand our this kind of solution. Of course, only including TB, but also contribute whole universe UHC concept. Yes, thank you. Thank you very much.
Thank you, Hirotaka, for your presentation and also covering for the Toyota Tsusho part. Really appreciate it. And yes, I found it a very unique combination, a unique partnership again between you. So I will ask that question later, but please allow me to jump into the panel discussion. And my first, and then after the panel discussion, if I have time, I will also ask some questions to the floor. I know you may have several questions to the speakers, and we'll try to make some time for you as well. Okay, it's first my turn. So I know, so this question will be mainly for Jacob and Elana, but both of you have covered some challenges that you're facing currently in the development of the TB diagnostics and vaccines, and also maybe some parts in treatments. And what potentials do you see in the involvement of the Japanese partner? And what expertise are you looking for currently in diagnostics or vaccine development?
Thank you for the question. Avi is all about partnership. So we really believe that no one organization can do all the work alone, right? And especially if we can find a partner that shares our mission of translating science into a global health impact, that is definitely a win. I've highlighted the challenges in my presentation. I think the biggest challenge is the lack of a correlate of protection to really be able to select candidates or to prevent this large investment of a phase 3 trial if we can maybe down select them before we get there. In terms of partnership, I mean, we need partners along all those stages of vaccine development. And I believe a partner like Japan, who has such a great record of managing TB, and I mean, you have all these resources and the R&D capacity to tap into would really be a great asset to anyone developing a TB vaccine.
Thank you, Elana. Jacob?
Yeah, I think also I would echo those comments. The Stop TB partnership, it's in our name. We're really thankful and grateful for the support that GHIT has provided to us and our partners. And I think that I would say early discussion, echoing what Elana was saying, the potential for that Japanese developers have is immense, and clear from the last presentation. Really great to see. And I've been here a few days having discussions, and we've obviously we discuss with many developers around the world on different diagnostics and new products. And one of the things that it is a problem is when developers come to Stop TB or whoever they're working with after the product is well along the lines of being developed, because there's often a not miscommunication, but there's misalignment with the expertise maybe that the developer has and the needs in high TB burden countries. And that can be because the test has very high costs. It can be because some product has real infrastructure needs. The example for X-ray is a good one. If you have to plug that X-ray in and you can only use that when you have electricity, there's a huge limitation, right? So you need to have the batteries, you need to be able to charge it, you need to be able to screen large numbers of people, not 10 or just a family. So there's many, those dialogues need to happen early on to really think about what types of products will be impactful in where people need the care.
Thank you, Jacob, as well. Yes, I think, yes, the partnerships and early discussion is really important. And this was, I think, clearly the key message for today. And also building onto the partnerships. So GHIT also believe in partnerships. And one of our requirements to apply for GHIT funding is to have at least one Japanese partner and one non-Japanese partners. So I'd like to ask the sort of the question to Hirotaka. So I found it really unique that Fujifilm, the company, now also developing pharmaceuticals, and Totetsusho, which is a trading company in Japan, has sort of come together to tackle this neglected tuberculosis together. How did you come to a partnership together? Can you maybe elaborate a little bit?
Yes, we had a good partnership before this project because they are trading company and we have a good deal overseas. That's a tender. We many times we tackle on to get the overseas tender with Toyota Tsusho. So we had already have a good partnership with them, and we have X-ray, portable X-ray and activities, but it's sometimes limited because the rural area is hard to reach because the road is no good, and we utilize our own vehicles, the very simple vehicles, and they have a strong Land Cruiser. This is go anywhere. Even if the road is very bad condition, and also they have the vaccine vehicle, and they have already PQ approvals, that kind of vaccine Land Cruiser. So we think we can collaborate X-Air, tuberculosis, and Land Cruiser. But not only take chest X-ray, but we should do the diagnosis by PCR. So we bring a PCR on site. Yeah.
Thank you. Yeah, it's interesting that the partnership has been built outside of the current target, but you never see what comes next from the existing partnerships as well. Thank you so much. So changing the point of view a little bit, I wanted to ask a question to all of you, and if each of you could comment shortly, is that are there any hurdles in the regulatory process or regulations or clinical trials or in the guideline developments when combating TB? May I start from Jacob?
The short answer is yes, of course. We see many different issues, and I'll just highlight a few. In tuberculosis, we when Dr. Nakatani was ADG and TB, WHO's TB department was in charge of making those recommendations, and we've now moved. WHO has moved to having PQ look at different classes of TB diagnostics. Unfortunately, this has slowed down greatly the ability of many products to get to become pre-qualified for reasons that are unknown to many of us. I think that there's just a real bottleneck in the process to get through WHO pre-qualification. The good news is that, or some good news is that there are other options. Global Fund, which is the largest, by far, the largest multilateral supporter of TB, has a committee that reviews products and can provide a recommendation that allows Global Fund to support and procure devices, WAMBO or PFSCM. There are procurement arms that can facilitate that, in addition, obviously, to Stop TB and GDF as well as others. But there are many bottlenecks, and then just another example for X-ray in South Africa, for example, it is a totally different situation to use mobile X-ray, ultra-portable X-ray, than it would be in Nigeria or Cambodia, where they've been using this for over a decade. in many active case finding situations, in country regulations can also be a huge bottleneck. So there's a lot of this idea of dialogue and thinking about how the product will be used is really important to understand the different country contexts and how the products can be used and the barriers to overcome them.
Thank you. I think I'll just continue where you just stopped. If you think about a clinical trial and having to take a vaccine to be trialed in participants, obviously you need to get regulatory approval. And also here in our trial space, we have different regulatory expectations in different countries. And a big part of our work is really understanding the local context and understanding what is required to get approval in a specific country where you would want to or need to do your trial. That is one aspect of it. The other aspect, if we think about more towards licensure and regulatory requirements for licensure, we have to do our trials. I've already mentioned that our trials for efficacy are very long, large, and expensive. And we have to do this to make sure that we acquire enough TB endpoints to make statistically meaningful assessments of efficacy. And to do that, we enrich our population by enrolling IGRA-positive participants, because someone who is infected with TB does have a higher risk of developing active TB disease. But then a regulator might require testing or proving efficacy in a non-infected population. To do that, you wouldn't need thousands of participants, you would need tens of thousands of participants and much longer trial duration for follow-up. So that is really not realistic. And I think if we can get to a point where if we prove efficacy in an IGRA-positive cohort and we prove safety and immunogenicity in an IGRA-negative cohort, that should be acceptable to allow the use of a vaccine in people who are infected or not infected with TB. And obviously, if a regulatory requirement like this sticks and you have to develop your vaccine like this, you would have to test for infection or not infection before you can administer your vaccine. And that is really not practical. So that is one aspect. And then similar to that is obviously we have to do our trials in endemic countries. And in these countries, most of our participants would have received BCG in childhood. So to have a regulatory requirement of proving efficacy in a non-BCG vaccinated population before a vaccine can be used in a non-endemic country is also not realistic. So I think that is sort of the crux of the regulatory challenges in the vaccine space.
Yes, we are manufacturers, so our first priority of regulation means the local regulations, each country's regulations, because we have a distributor and subsidiary in each countries, and we'd like to distribute our equipment product to each country. So we can do through the regulation of each countries, and we have the specialized organization, a team. But many typical Japanese company is not good at to think about the international regulation like PQ and GDF also. But it is very important to go in the market and get the credibility for the product. So we are very thankful, and it's important to get the advice and support from Stop TB Partnership and GHIT, and we finally get the approval of GDF. And after GDF, we reach many countries we cannot touch countries, and many inquiries from the countries. So we should have the expert in the own company. Now Fujifilm is improving this point, not have the specific organization. Someone very someone have very deep knowledge for this international regulations, but if he will move to other department, the knowledge is gone. So we'd like to tackle on this issue. Maybe Japanese typical company is almost the same situation, I think. Okay.
Thank you so much for the variety of answers to my questions. That was really helpful. Then I'd like to open to the floor for any questions to the speakers you may have. And it will be helpful if you could make sure to whom you're addressing your question to. And when you before you say your questions, please state your name and affiliation if possible. And if you could raise your hand, if any questions. The mic will get to you.
Hello, my name is Peter Warner, and I'm at the Gates Foundation, primarily working on TB drugs, a lot with Nada Fatui. I'm interested, this is a question for Jacob Cresswell, I think primarily. It's very interesting to hear what's happening on the diagnostic and biomarker front. Clearly there are a number of different use cases. And my understanding from your presentation is that you were primarily focusing on case finding. So one question that's coming up increasingly is, should we be thinking about looking for diagnostics or biomarkers that will allow us to determine, before we start treating a patient, whether they're going to need to have the full 6 months of treatment or whether they would actually likely be cured in a shorter period of time? And I think this is an interesting question, particularly as we start to develop new drug regimens, because, of course, at this current situation is that we're almost certainly over-treating many patients in order to be able to treat those which are particularly hard to treat. I know it's a scientifically very challenging area, but I'd be very interested in the panel's and particularly Dr. Cresswell's thoughts on this particular use case. Thank you.
Sure. Thank you so much. And it absolutely is. I would agree. So right now there are already several initiatives that are looking for specifically for children, right, and shortening treatment regimens for children. And just recently, in October, we had a meeting with WHO, many partners, to really discuss what has been touched on a little bit this morning, the concept of asymptomatic TB, subclinical TB. I think we're moving to call it asymptomatic TB in the TB community now, and thinking about, especially with this group of people who do not report symptoms, if they need a full what we now have a full course of treatment, or something far less expensive, long-term, pill burden, everything will be sufficient. And I think we're just beginning to think about this, I think we're in the early stages of these discussions and probably some debates, but clearly with a greater focus on the need to identify the large proportion of people who have TB, at prevalent TB, who are asymptomatic, and many of those people may revert without treatment. That are we likely over-treating this large group of people? So I think that that's absolutely going to be something going forward that we're going to be looking at, and hopefully with, again, some of the tests that can be used at a much broader scale, wider scale, identify people that would benefit from shorter treatments. I think I think, not to give a vague answer, but we're still early stages of those discussions.
Thank you, Jacob, and thank you, Peter. Any Any other questions? Yeah, the mic will get to you.
Since we still have time and no one wants to ask, so I'm Sam Cooney. I'm Sam Cooney from GHIT, the CEO. Okay, I have a question to Jacob. Especially we are supporting, GHIT is supporting the Fujifilm for TB lamp, and maybe hopefully, it will be kind of approved as soon as possible. So what do you think are the kind of best way to use this screening the TB lamp and also X-ray? Because you need and we need kind of strategy, to implement. For example, in Japan, we are quite successful in this controlling TB because we use this kind of screening at 3 places: school, community, and the workplace, right? And we need a kind of such kind of a strategy for this screening and also a kind of CAD. So what do you think? Just personal opinion is fine. Yeah, thank you.
Thank you, Dr. Cooney, for the support of course, first and foremost, and the question. There's a couple things that I would say. First is the relationship that we have between screening tests and diagnostic tests, specifically with AI and CAD. One of the really exciting things that AI with chest X-ray can do is it provides essentially a kind of a continuous variable. You have a likelihood of people who you get an abnormality score. So the software will read the chest X-ray and say 0.9 or 90 or whatever, usually between 1 and 100 or 0 and 1, right? And it's not probability, but it's a likelihood. So as you get higher abnormality, TB-related abnormality, you're more likely to test positive for TB. And that opens up a lot of options for thinking about targeting who should be tested, how they should be tested, with what type of tests that we simply can't have with a human reader, because generally a human reader will say this is suggestive of TB or not. So that's one area that I think there's a lot of potential to explore how to use any test and CAD. Specifically for urine lamb, currently the test that is WHO approved, Alir's lamb test, is recommended for populations who are HIV positive. Used to be only for very, very sick, low CD4 count, people with very low CD4 counts. It's been recently expanded. But the real potential, both from a commercial perspective and selling tests, but also from a coverage of TB diagnostics, is to be able to use this test in much larger populations, so outside of people living with HIV alone and children, and then the opportunity that a urine test provides, I think, or one of the opportunities, is just this ability, a lateral flow test, to be able to test at much lower levels of the health facility. You don't need the same infrastructure. And then you can start thinking about, can this test be done? I mean, it's a stretch to say like a pregnancy test, but can this be sold and provided at local pharmacies where you could buy the test, produce the sample, and have it tested there, and think about different ways of expanding access to people through this test, even though it's likely not going to be as sensitive as some of the molecular assays. So these tests that don't require sputum open up a lot of possibilities in terms of thinking about different ways we can deploy them and use them.
Thank you, Jacob, and thank you, Sam, for your question. If no question from the floor? Okay.
Hello, thank you very much for the great discussion. I learned a lot. I'm Yuri Okura from the University of Tokyo Hospital Biodesign Department. I have a question regarding TB diagnosis. So the misalignment was mentioned during panel discussion, and my question is that, do you think that local unmet needs regarding TB diagnosis is different depending on the countries, or do you see some like common needs among those countries which has certain a number of TB patients?
I guess I'll take that. The general answer I would say is that yes, there's a baseline of, there's a big difference between obviously what is available in Japan and what is available in high TB burden countries. With that being said, there's a huge difference between a primary care facility in Vietnam, which may have chest x-ray, and a primary care facility in rural Ethiopia, which probably doesn't have any diagnostic tests for TB. So as a common denominator, we should be, I think, we need to be focused on bringing the diagnostic tests closer to where people first seek care in high TB burden countries, and think about, probably not, you can't say universally, but thinking about places that don't have very well-trained staff. So at most a nurse, and maybe not even a nurse. They will have poor electricity, or maybe even no electricity, and they're not having a huge patient volume. So thinking about things that can be used in those type of settings, ideally, and you can go up from there, but that's how I would think about answering that question. Thanks.
Thank you, Jacob, and thank you for your questions. And unfortunately, the time has come to an end to the session one. Time flies really quickly. And thank you again for Jacob, Elana, and Hirotaka for your wonderful presentations and discussions. And thank you, everyone, for listening. Thank you again.
GHIT Fund. Fight neglected diseases through partnerships.